Good morning. On behalf of the Brain Injury Alliance of New Jersey, I'd like to welcome you to this session, this workshop. Before we get started, I want to remind everyone about CEUs. You must complete the 5 evaluations as required to earn continuing education units. Follow the links in the email you received about this seminar to complete them. And don't forget to visit the website BIANJ.org to view the poster presentations. These research posters are being presented by senior level students in healthcare. This workshop is entitled Clinical Applications of Neuroimaging. Our speakers this morning are Ekaterina Dobriakova, Nancy Chiaravolati, and Olga Bukrina. Doctors Chiaravolati, Dobrikova, and Bukrina are research scientists at Kessler Foundation. They work at the intersection of clinical neuropsychology and neuroimaging with the goal of facilitating development of interventions and rehabilitation techniques informed by neuroplasticity. Today, they will talk about new research in cognitive rehabilitation and neuroimaging, as well as future directions in cognitive rehabilitation and neuroimaging. Please, if you have any questions, keep them until the end of the presentation. You may enter them in the Q&A tab, and they will be addressed during the Q&A in the later part of this workshop. This workshop will end promptly at 11:55. Thank you.
Good morning. Thank you for joining us for this workshop on neuroimaging. My name is Ekaterina Dobrikova, and I'm going to start the workshop and then give the screen to Dr. Chiaravolati and then subsequently to Dr. Bukrina. So we will start the workshop with talking a bit about neuroimaging modalities. Specifically, first I will tell you just briefly about non-magnetic resonance imaging modalities, and then we will jump into magnetic resonance imaging, and I will present an example of an MRI or magnetic resonance imaging study that we just finished at Kessler Foundation on learning in traumatic brain injury. Then Dr. Chiaravolati will talk more specifically about the application of fMRI in clinical research, focusing on the modified story memory technique in individuals with TBI, which is a double-blind controlled clinical trial to improve memory. And the workshop will end with a presentation by Dr. Bukrina, who will talk about future directions and another approach that's possible with MRI, specifically arterial spin labeling, and she will give an example from her stroke research. Okay, so in terms of non-MRI neuroimaging modalities, you're probably familiar with a computerized axial tomography or a CAT scan. It's used in a lot of hospitals to assess damage to soft tissue structures, and it is basically a fancy X-ray and requires concentrated X-ray exposure to get the images. Another type of a scanner is a positron emission tomography scanner. It allows to do functional neuroimaging because it reflects brain activity based on movement of injected radioactive tracers. So in that respect, it's a pretty invasive imaging modality, but through the digestion of the radioactive tracers, we can see glucose metabolism in the brain and hence the brain activity. Two other types of non-MRI modalities that are used for imaging are the electro and magnetoencephalography. These modalities have, so to say, poor spatial resolution, but very good temporal resolution. You can see the data output on the right of the side of the screen with the woman going through the EEG recording and the man on the screen doing the experiment with MEG. So EEG measures electrical potentials of the brain through electrodes placed on the surface of the scalp. And MEG measures small changes in magnetic field caused by electrical activity of neurons. And then we have the MRI, or the magnetic resonance imaging scanner. It is a pretty non-invasive scanner because there is no X-ray exposure, and usually to get your brain scanned, it's not required to be injected with any radioactive tracers. And it's very versatile scanner because it allows us to obtain these high resolution structural images that you can see here. And from that, we can also evaluate the total brain volume, the volume of the white and gray matter, and also the volume of specific regions that you can see in color here. And from that, we can compare the volume of, let's say, a TBI sample to a healthy control sample and determine whether there are differences between the groups. It also allows us to evaluate the integrity of the white matter. On this image, you can see different white matter tracts that have specific motor and cognitive functions. And again, we can compare the integrity of these tracts between groups. In addition, we can look at gray matter activity using functional magnetic resonance imaging while someone is performing a particular motor or cognitive task. And we can also look at what's happening in the brain during rest. So more specifically, when we do functional MRI, what we actually measure is the metabolic correlates of neuronal activity. We're not measuring the neuronal activity itself, but we measure blood oxygenation that changes in response to metabolic requirements of neurons. So for example, when you're trying to memorize a phone number and you keep repeating it in your head, this causes neuronal activity, and subsequently that causes increase in the blood flow. In turn, that causes increase in blood oxygenation, and that's what's being captured by the MR signal in the MRI scanner. In terms of application, what we can do with functional MRI, we can look at task-based fMRI. So this approach has a long history from experimental psychology. Before the advent of MRI, experimental psychologists were doing their experiments, let's say, on a computer. And with the advent of the MRI, the psychologists were able to bring the same experiment into the scanner, where a person was doing the same thing, but in the scanner. And that allowed to examine what happens during specific cognitive tasks, such as, for example, what happens when someone is presented with an outcome. And if the outcome is rewarding, you can see on the picture here on the right, we have activation of this specific brain region, which is the striatum. During reading, it's also been shown that there are different brain regions, so different networks being activated during listening comprehension and reading comprehension. But at the same time, the networks or brain regions still overlap, as you can see in figure A here in white. And more recently, researchers started looking at what happens in the brain during rest. So when someone is not engaged in any particular task, but is just mind wandering. So there is something happening, which is good for us. And through resting state scans, several networks or brain regions that have similar activation through time have been identified. So there is a primary motor network, left parietal frontal and right parietal frontal, and the default mode network. So knowing this information, how can we apply this to issues experienced after traumatic brain injury? In my research, I'm doing this through the prism of outcome processing, which is an important component of adaptive behavior. And when I'm talking about outcome processing, what I really mean is how well we and whether we can learn from outcomes. Outcomes are quite important during learning because basically outcomes determine whether you continue with a specific course of action or whether you switch your behavior. And we have to process and learn from outcomes throughout the day and in different situations. For example, at work, you often receive feedback from your boss. If it's positive feedback, you know that your performance is good and you should continue to do the same. But if you get a ticket for driving, that's probably a sign you should improve your driving behavior. How is this relevant for rehabilitation? Well, disrupted outcome processing can lead to disrupted learning during rehabilitation that so many individuals with brain injury need. If we think about motor rehabilitation, we need to be able to process outcomes and instructions before an action becomes automatic. During cognitive training, again, you need to be able to process outcomes and feedback from a therapist. So inappropriate outcome processing can lead to a decrease in strategy use and perseveration of incorrect action. A few years ago, we showed that in healthy individuals, the context of outcome presentation matters. Depending on whether an outcome is presented immediately after one performs an action or after a delay, different networks are being activated. Healthy individuals learn from both immediate and delayed outcomes, but when the outcome is presented immediately, the striatum is activated, which is a region that you can see in green on the right side of the screen. When an outcome is presented after a delay, the lentiform nucleus is activated, which you can see in orange. So we also recently showed that individuals with TBI exhibit deficits in learning from immediate outcomes. As you can see on the graph, individuals, the healthy control group, perform significantly better when they are required to learn from immediate outcomes compared to individuals with TBI. Additionally, individuals with traumatic brain injury exhibit reduced activation of the striatum during immediate outcome processing. So that region that on the previous slide I showed you was responsible for processing and learning from immediate outcomes. So now the question is whether we and how can we circumvent this inability to learn from immediate outcomes so we can still achieve learning. And based on the findings from healthy individuals, maybe we can circumvent this inability to learn from immediate outcomes by altering feedback or outcome timing and presenting outcomes after a delay, with the idea being that this will activate a different brain network. So we might see a switch from the striatum to a different, either to the lentiform nucleus or to a different brain region, because we know that neural trauma usually leads to neuroplasticity and changes of the functions of different brain regions. So this has already actually been shown in Parkinson's disease. As you might know, this disease is characterized by degeneration of dopamine neurons, leading to motor deficits as well as to non-motor deficits. And Shohami and others back in 2004 showed that individuals with Parkinson's disease show disrupted learning through immediate outcomes. So that's one of their non-motor or cognitive deficits. As you can see on the graph, healthy control individuals again perform significantly better when they have to learn from outcomes compared to individuals with Parkinson's disease. It's also been shown that when outcomes are presented after a delay, individuals with Parkinson's disease perform as well as healthy control participants, as you can see on the graph on the left. Furthermore, if we look at brain activation, individuals with Parkinson's disease actually are not only able to learn from delayed outcomes, but they also activate the hippocampus. And it is possible that a similar picture is observed in individuals with TBI, because there is evidence showing that dopamine levels vary depending on the stage of traumatic brain injury, with acute stage of TBI being characterized by increased amounts of dopamine in the brain, while chronic stage of TBI is characterized by decreased dopamine levels in the brain, which is what we see in individuals with Parkinson's disease, but of course due to a different etiology. So in the current study, we wanted to find out whether we can circumvent this deficit in learning from immediate outcomes in individuals with TBI by presenting outcomes after a delay. And we also wanted to examine what mechanisms will be involved in learning from delayed outcomes. To answer these questions, we recruited 29 participants with traumatic brain injury. They were all in their chronic stage and had moderate to severe brain injury. They performed the following experiment in the brain scanner. This is a brief layout, and I will go in more detail about each phase of the experiment. So the experiment started with a study phase outside of the MRI scanner, where participants had to learn word associations, so paired associate word learning task. Then during the scan, during the first portion of the scan, the words were separated onto 3 outcome conditions, and participants were presented with outcomes for words in the immediate outcome condition, but not for the other 2 conditions. And during the second portion, or the latter portion of the scan, participants were presented with outcomes for words in the delayed outcome condition, but not for immediate or no outcome conditions. And then the experiment ended with a test phase, allowing us to examine whether there was improvement in learning between the study phase and test phase. So basically whether participants' learning improved from immediate and delayed outcome presentation. So now more specifically, here's what happened during the study phase. On each trial, participants were presented with a target word and 2 options underneath, where one of the options was highlighted in green, indicating to participants that that option was the correct match for the target word. Then during the scan, for paired associates in the immediate outcome condition, participants were presented again with a target word and 2 options underneath. They had to make a selection to match the target word with one of the options below. And right after their response, they were presented with an outcome screen indicating whether their selection was correct or not. During outcome phase 2, participants were reminded of their selection that they selected during outcome phase 1 through the blue highlight. And then they were presented with a control screen since they already knew whether their selection was correct or not. During the delayed outcome condition, basically the opposite happened. Participants again had to select either the first or the second option as a match for the target word, and then they were presented with the control screen. So they didn't know immediately whether their selection was correct or not. But during outcome phase 2, again, we presented them with a reminder of their selection, and then they were presented with an outcome indicating whether the selection that they selected during outcome phase 1 was correct or not. So in that way, we have a delay of about 25 minutes between the action performed during outcome phase 1 and the outcome presented during outcome phase 2. During the no outcome condition, which is basically our control condition, participants were always presented with a control screen. So they didn't know whether they responded correctly or not. And during the test phase, all of the words were combined, no outcomes were presented, and participants, again, simply had to pair the target word with one of the options underneath. So our results showed that delayed outcomes led to improved in learning. As you can see here, there is greater benefit for trials and words in the delayed outcome condition compared to immediate and no outcome conditions. And also we observed different brain networks activated during delayed and immediate outcomes. As you can see on the picture on the right, delayed outcome processing activated a small network of regions in the parietal lobe, suggesting that these regions were responsible for learning through delayed outcomes. And learning through delayed outcomes is probably more efficient because we have very constrained activation and not a lot of it, which is the opposite of what we see for immediate outcome processing. We can see the striatum still being activated, but because the learning is not, the learning accuracy for immediate outcomes is not as high, probably other regions have to compensate, and hence we see a larger network of brain regions being activated in addition to the striatum. So to summarize, during delayed and immediate outcomes in healthy control participants, we observe learning. So the healthy control participants learn from both immediate and delayed outcomes. But what is interesting is that the delayed and immediate outcomes lead to activation of different brain networks. In TBI, we can try and circumvent the deficit in learning from immediate outcomes by presenting outcomes after a delay that leads to improvements in learning and activation of a different brain network. So basically, the context of outcome presentation leads to behavioral and brain changes. So what we can take from this is that MRI and functional MRI can be a valuable tool for documentation of brain changes associated with cognitive manipulations that I just presented to you. And also it can be a valuable tool for documentation of brain changes associated with cognitive rehabilitation. So far, in terms of cognitive rehabilitation, there are very few studies that utilize both functional MRI and cognitive rehabilitation. Existing studies examine brain changes after attention rehabilitation or memory rehabilitation. And one of the memory rehabilitation studies is the modified story memory technique, which is a double-blind controlled clinical trial developed by Dr. Cervellati. At this point, I'm going to give the screen to her. Before we do that, I just want to thank my funding sources and give the floor, or the screen rather, to Dr. Cervellati. Thank you.
Okay, thank you, Dr. Dobrikova. I am going to share my screen now. Okay, so in much of the research that we've been doing at Kessler Foundation in cognitive rehabilitation, in traumatic brain injury, as well as in other populations such as multiple sclerosis, we've been applying neuroimaging to be able to look at changes at the level of the brain from before to after the cognitive rehabilitation treatment. So I'm going to be talking about that a little bit today, giving you two specific examples of some work we've done looking at changes at the level of the brain from before to after cog rehab. So this group is very familiar with traumatic brain injury. We know that there are common symptoms that people are dealing with every day following traumatic brain injury, which include physical deficits, changes in emotional functioning, behavioral changes, as well as cognitive deficits. Cognitive deficits are very common in folks who are living with traumatic brain injury, and they include deficits across a number of domains, including executive functioning, processing speed, working memory, and attention. Much of the work that I have done has really focused on the memory dysfunction and how to effectively treat memory dysfunction in this population. And this is largely because memory dysfunction really is a cardinal feature post-traumatic brain injury. And it's a very common complaint, not only in people who have traumatic brain injury, but in other populations as well. So it really is something that memory is something we really rely on tremendously in our daily life. And we really need to look for effective means of improving our memory functioning across populations. So we've developed the Kessler Foundation Modified Story Memory Technique. This is a cognitive rehabilitation protocol that consists of 10 sessions. The sessions are done twice per week for 5 weeks. They last approximately 45 to 60 minutes, depending on how quickly the patient works, because it's really the speed with which you move through the session is really dependent upon the patient. Across the 10 sessions, there are 2 different strategies, memory strategies, that we focus on. In sessions 1 through 4, we focus on imagery. So in those sessions, a story is presented. The participant is read instructions and they're explained that each story contains capitalized words that they have to remember. Their job is to create mental images of each storyline so they can picture the characters, the setting, etc. Now, in this setting, when we're providing the story, the context of the story is already there. We're only teaching imagery. So the 2 strategies that we're teaching patients within the story memory technique are context and imagery. With the first 4 sessions, the context is already provided and we're just focusing on imagery. So this is something that the patient might see, a story such as this. They're already told that they're supposed to focus on those capitalized words and try to remember them by forming mental images. So within each session, we go through the story once, and then we test recall and recognition. After we test recall and recognition, they're provided with guidance. And one important part of this protocol is there is a manual that the trainer follows. So, and that's important for a couple of reasons, but the main reason is really that we know that the treatment we're providing within our research protocol is the treatment that everyone can provide. So we know exactly what was done within each session, and that makes it replicable. So guidance for imagery is provided following that first story. So they're told to concentrate on forming a mental image of a chunk of the story, and that they can chunk several pieces of information into images. So they may have 3 pieces of information within one image. And then they're also taught to transform verbal information into pictures. The theory behind this originally was that they would be engaging additional brain mechanisms in learning this verbal information. And I'll explain what we found when we did our imaging, when we gathered imaging data, in just a few minutes. So in session 5 through 8, we focus on context. And in these sessions, a list of words is presented. So now we've taken the context of the story away, and what we're having the patient do is provide their own context. They're instructed to make up a story using the provided list of words, and they're asked to create an easy to visualize story. And in some cases, that means the story might be quite bizarre, because strange things are easier to visualize than everyday things often. For other people, it's easier to visualize everyday things. So this is where the patient really has to come up with what they feel is easier for them to use. So they're told here that they're continuing to use imagery, or they are continuing to use imagery. And now what they're doing is adding this context that's meaningful to them. It's not the context we're providing for them. So this is an example of what they might see. This is a list of words from the treatment protocol. And in this case, they are asked to take these words and incorporate them into a meaningful context, such as a story. Now, as clinicians have started to use the story memory technique, this is the part where they've kind of changed it a little bit. So we have a clinician that we've gotten a lot of feedback from Connecticut. And what she does is she breaks this down into 2 different lists, because she found that this was too many words for one person to work with at one time. So she does a list of 10 and then another list of 10. And she finds that that works well for her patients. So despite the fact that we have this highly manualized, standardized treatment, which makes it highly replicable, what is important is that clinician judgment is absolutely essential. The clinician is the one that knows the patient, and the clinician knows what the patient can do and what the patient might struggle with. So it's the clinician that really has to make those decisions in terms of maybe it's better to present only 10 words, or maybe this particular patient is ready for 20 words, or maybe somewhere in between. But that's really clinical judgment, and we cannot put clinical judgment aside. That's really an essential part of cognitive rehabilitation. So this is an example of what patient might come up with. So if they have words like automobile, bottle, cash, church, these words really have nothing to do with each other. The task for them is to take these words and put them in a meaningful context. And in the beginning, this takes a long time. So this is when some of those sessions may really be quite long because they have to take their time and figure out how to put it into a context. Now that does get easier as time goes on. So the sessions might get shorter later in the treatment. So this is something that someone might come up with. Sunday after church, I need to take my automobile to the bank to get cash for a bottle of wine. So they've taken these unrelated words and put them into a meaningful context that they can then visualize. Just before I go on, in terms of the visualization, patients may engage in the visualization differently, and that's okay because they really need to use their strengths in creating the visualization that's appropriate to them. So when you talk to people, some people visualize pictures and they might move from one picture to another when they're kind of working through their story. Other people might visualize the material in more of a movie. So they might kind of put everything together and have one image moving into another image. Some people visualize bizarre things that don't really make a whole lot of sense. Other people like to make things look more concrete and more applicable to their daily life, and they may use images, engage images from their daily life because that's easier for them. So those differences are differences that we want to capitalize on because people are using their strengths to maximize the benefit that they get from the treatment. Now, one of the unique parts of this particular treatment protocol is sessions 9 and 10. Sessions 9 and 10 focus on everyday life. Generalization to everyday life is absolutely essential. And that is where a lot of the cognitive rehabilitation literature is quite limited. So this particular protocol takes sessions 9 and 10 and focuses on everyday life activities that might be memory demanding, such as a shopping list. You have to go to the store, you have to get eggs, milk, shampoo, bagels. How do you remember that when you don't have your list with you? You have a to-do list any given day of the week. You have to buy groceries, take medicine, pick up the kids, go to the cleaners. How do you put those things together? And within these 2 sessions, the patient is taught to make up a story using a provided list of words and then to create a story that's easy to visualize and to visualize that story. So we've published on this quite a bit in both traumatic brain injury and multiple sclerosis, and we've provided class 1 evidence that this modified story memory technique is effective for persons with traumatic brain injury as well as persons with multiple sclerosis. And right now we have several other clinical trials ongoing in other populations. So the testing of this original treatment protocol in traumatic brain injury was funded by NILR as part of our TBI model system. The final sample size was 69. We did pre and post, we did testing. We did a neuropsychological assessment. We administered questionnaires regarding a patient's everyday life. And then we also conducted neuroimaging. So this is some of that data. From before to after treatment, we saw a significant improvement in prose memory. So patients were quite easily able to apply context. And if you look at the red line here, you see a nice change in their ability to remember a story from before to after treatment, whereas the control group doesn't change. We also saw, and this is pictured again a different way on the left side of the screen, this is percent improvement in prose recall. So you see that our treatment group, 53% of the people in our treatment group show an improvement, while only 18% of our control group show any change. On the right side of the screen, you see an everyday memory task, which is the Rivermead Behavioral Memory Test. And what we see here, again, is a very nice improvement in the treatment group when we see a small improvement, less improvement in the control group, with very few people showing a practice effect. Now, we did collect neuroimaging pre and post treatment, and we did find some very interesting changes in terms of brain activation. So on this screen, you see that we saw significant changes in the default mode network regions. And I'll explain this in just a bit, but what we see is that the treatment group shows an increase in activity in the default mode network from before to after treatment, while the control group shows a decline. And these are both two different areas of the default mode network. So we analyze this data in more of a network analysis rather than looking at just discrete areas of activation. Now, in a different network in the brain, we see the opposite pattern. So this is in the executive control network. And what we see in the executive control network is a decrease. So we see a decrease in activation in the treatment group from before to after treatment. And we see an increase in activation in the control group from before to after treatment. We see that across three regions of the executive control network: the right dorsolateral prefrontal cortex, the supplementary motor area, and the inferior parietal lobule. So now what does all this mean when we put these things together? When we look at these two findings, we see decreased activation post-treatment in the executive control network. That was the slide I had just shown you. For the executive control network, we know that encoding, what that means is that encoding is less cognitively demanding or more efficient post-TBI, post-treatment, post-treatment. So what this is telling us is that the patient is applying new and more efficient strategies to learning. So the executive control network is highly active when you have to put a lot of effort into learning or understanding something. From before to after treatment, we saw the executive control network decrease in activation. So what that's telling us is that the brain is becoming more efficient in learning and remembering this information. Now, again, in the default mode network, we saw the opposite. The default mode network is suppressed during performance of a cognitively demanding task. So by virtue of the fact that we saw the default mode network increase in activation, that's post-treatment. That's telling us that the learning task has become less cognitively demanding post-treatment, and the default network can then be active as it is when you're not engaging in a cognitively demanding task. So these two networks are often anticorrelated, and the pattern of change from before to after treatment has shown us that the brain is actually becoming more efficient from before to after treatment at engaging in these memory tasks. And I should mention, I apologize, I failed to mention that the memory task that they were completing was learning a list of words similar to like a CBLT, but they were doing that within the scanner. So they were learning this list of words in the scanner. So it is quite a demanding learning task. Now, when we thought more about cognition, we wanted to do this in another domain as well. And in this case, we have much less data, but it is interesting nevertheless. So when we think about cognition, learning and memory really is a higher order cognitive function. There are a lot of other cognitive capacities that go into learning and memory. You have to pay attention. You have to have intact working memory in order to get to the learning and memory and for that learning and memory to be efficient. In many cases, you need to have intact visual spatial processing depending on the material that you're learning. Your processing speed has to be intact because you have to be able to process a large amount of information within a circumscribed period of time. And then finally, executive control. And executive control can really be looked at as both a feeder into learning and memory and as a higher order executive function, a higher order cognitive process itself. So in this case, we're thinking of it as a feeder into learning and memory. So in looking at some of these factors, we really decided to focus in on processing speed and try to understand a little bit more about processing speed, because processing speed is often a deficit that we see following traumatic brain injury, and it is actually the most common deficit that you see in persons with MS. So in looking at processing speed and memory, and this is one of the reasons we chose to focus in on processing speed a little bit, you see these significant correlations. These are all along the top in the gray, these are all processing speed measures. And along the left side, you see memory measures that you likely recognize, SRT, CVLT. And in here, you see all these highly significant correlations between processing speed and learning and memory. So this tells us that if we look at processing speed and we try to intervene on processing speed, that might in fact lead to better learning and memory performance as well. So it's a different way to attack the problem. So we had another clinical trial that was recently concluded looking at speed of processing training to improve cognition following traumatic brain injury. This was also funded by NIDLR as part of our TBI model system. It was a randomized clinical trial. We included 80 participants, all moderate to severe TBI, and then they were randomized to a treatment group or a placebo control group that completed a processing speed intervention. The intervention was a 10-session computerized processing speed treatment. It was administered via the laptop, again, very highly manualized. And this is an intervention that's used extensively in normal aging. There are 3 levels of engagement in the task: single discrimination, and then once you reach 75% accuracy, you move on to the next level, which is a discrimination task with a peripheral target. Again, once you reach 75% accuracy, you move on to the 3rd level, which is a discrimination task with a peripheral target that's embedded among distractors. So the task gets more and more difficult as you move through the treatment. Again, we did outcomes before and after treatment, very similar study design to the story memory technique. The outcomes consisted of objective cognitive performance, which was a neuropsych assessment, the traditional means of evaluating a cognitive rehab protocol. Cognition in daily life, and for this we used the TIADL, which is an occupational therapy-based assessment that many people might be familiar with, to try to look at the impact of speed in daily life activities. And then we looked at subjective cognition in daily life through questionnaires. And we also looked at emotional functioning and awareness and self-efficacy. So this is some of our pilot data. We haven't analyzed the full trial yet, but what we're seeing in our pilot data is a significant improvement in the treatment group on the letter comparison task. So this is a processing speed task. And we see that from before to after treatment, the treatment group shows a nice improvement in their processing speed. The TIADL, which is a everyday life task, also showed a significant improvement in the treatment group, where a lower score here is better. So we see our treatment group is performing the task much faster because this is speed to completion than the control group. The control group is also showing a practice effect, but the treatment group is showing a much larger change from before to after treatment than the control group. Now, what's interesting is we do have very limited imaging data on this protocol, and the imaging data we see post speed of processing training is very different from what we see post memory retraining, and that's really exactly what we want to see. That's telling us that our imaging data is giving us really useful information. So whereas with the memory retraining data, we saw changes in specific networks that were responsible for efficiently processing and remembering this information, in speed of processing training, we see that the brain is overall more active in processing this information, and hopefully that does correlate with their speed of processing and their change from pre to post rehabilitation as well. So just to explain this slide, on the top you see a control participant before processing speed training on the left, and then on the right you see an experimental participant. This is someone who underwent treatment before processing speed training. And on the bottom, you see the same participants. So there's very little change and actually decreased activation from before to after speed of processing training in the control participant. Whereas in the participant that underwent the training, we see this increase in activation that would correlate with their improvement in speed of processing from before to after treatment with the processing speed training. So why use fMRI? Well, fMRI allows us to understand why something works, not just if it works. The neuropsych data we're collecting is telling us whether or not the intervention works. But what the fMRI is telling us is what's happening at the level of the brain so that we can understand why it works. And that's really what we've been using the data for to date. The next thing that fMRI will help us do, or may help us do, is understand who benefits from treatment and who doesn't. And we haven't really gotten to that level of analysis with the data yet, but that's really where we're hoping to go. We're hoping to be able to develop some sort of mechanism for looking at whose brain is changing efficiently and whose brain is not. And we haven't really been able to get to that yet. The other thing that we hope fMRI will allow us to do is determine if the effects of cognitive rehab really are restorative or compensatory. So we talk about restorative cognitive rehab and compensatory cognitive rehab in clinical domains from a clinical perspective. But if we are able to look at this data at the level of the brain and see what's changing in the brain, then we're actually looking at that and classifying these systems based on neuroanatomical evidence. What that could potentially do is allow us to combine restorative and compensatory treatments that have different effects on the brain together to maximize benefits. So that's really where we can go with fMRI that would really be able to help down the road. So of course, I want to thank my funding sources for all of this work. And with that, I'm going to, my email is at the bottom of the screen, and I'll put it into the chat later so that everyone has my email address and can feel free to contact me with any questions or comments. And I'm going to turn it over to Dr. Bocrina so she can talk more about the different imaging modalities and other applications for them.
Thank you, Dr. Cervellotti. I'm just going to take a few seconds here to change the screen. Okay, so in this part of the presentation, I'm going to talk about future directions and clinical applications of neuroimaging. So clinical decision-making in the 21st century must rely on objective neurophysiological data. And this is exactly what neuroimaging can provide. And the value of neuroimaging in neurorehabilitation can be broken down into 3 components. First, it can help us understand the natural progression of disease and recovery to help determine the optimal targets and timing of treatment. Second, it can help us identify biomarkers of treatment response, and that will help us select treatment candidates and determine if treatment is actually working by measuring changes in the biomarker. And it can help us improve understanding of the treatment mechanism, which ultimately will lead to an improved availability of different kinds of therapies and will help select appropriate treatment. So in the data that I will present to you today, I will focus on the first component, which is understanding the natural progression of disease and recovery. And first, I'd like to spend a few minutes talking about the role of cerebral blood flow in brain injury and recovery. So if you would like to know how brain injury impacts brain function, you might want to use functional neuroimaging. And functional neuroimaging records the BOLD response, the blood oxygen level dependent response. This is a canonical depiction of this type of response where a stimulus is presented and then you see a brief initial dip in the BOLD response, which then increases up to a certain peak and then slowly falls back to the baseline. And what happens during this period is the neurons that respond to this particular stimulus increase their firing rate, and that means that they're consuming more oxygen, so they increase in oxygen metabolism. This may also increase cerebral blood volume of venous blood compared to arterial blood, and ultimately that leads to a change in this ratio, which the BOLD response is sensitive to. This is the ratio of deoxyhemoglobin to oxyhemoglobin. In other words, oxygenated hemoglobin to deoxygenated hemoglobin. And because of the different magnetic properties of these 2 different types of hemoglobin, the change in this ratio leads, in this case, to signal loss. Then, through neurovascular coupling, the neurons that are consuming oxygen are telling the blood vessels to supply more of oxygen. So the process that's called neurovascular coupling. The blood vessels dilate and provide increased regional cerebral blood flow to the area that needs oxygen. And this leads again to the change in this deoxyhemoglobin to oxyhemoglobin ratio, which then leads to signal gain, which we see here in this nice peak. But to summarize, the BOLD response is a sum of several processes, including increase in neural activity, cerebral metabolic rate of oxygen consumption, neurovascular coupling, cerebral blood volume, and regional cerebral blood flow. And just to point this out, only 2 of these are neural factors, and the other 3 are vascular factors. So this is why understanding cerebral blood flow is so important to our measurement of brain function with functional neuroimaging. And so when we talk about cerebral blood flow, we often talk about this notion called perfusion, which is the delivery of oxygen and glucose to tissues by means of blood flow. And we know that brain perfusion alternations are seen in brain injury. In particular, hyperperfusion or decreased blood supply is seen in acute stroke, in TIA, chronic cerebrovascular disease, and TBI as a result of vasospasm and impaired autoregulation. And autoregulation is an innate process for maintaining constant blood flow to the brain. Sometimes there's also hyperperfusion or abnormally increased blood flow, which can cause an increase in intracranial pressure, and so it's also negative. And this is sometimes seen in TBI due to impaired autoregulation, and in some cases with hemorrhagic stroke. So following brain injury, the brain goes through these natural phases of post-injury recovery. And in the acute post-injury period, there's typically a decrease in brain activity and perfusion. This is followed by subacute post-injury period where brain activity and perfusion may increase or decrease. And finally, a leveling off of brain activation and perfusion during the chronic post-injury period, although this may not be at the level that it was pre-injury. So let's say that you want to use a particular intervention during the subacute post-injury period, and you may want to know how this intervention impacts brain function. So what you would do is record pre-intervention functional neuroimaging, apply the intervention, and then record post-interventional functional neuroimaging, and then you compare the 2 sets of data to see if there are any changes in the brain. However, what you don't know is whether the resulting changes are a result of neuroplasticity or better hemodynamics, because both of these changes are happening in the subacute post-injury period. And so to measure some of this impact of hemodynamics, there are a type of neuroimaging scans called arterial spin labeling scans. And these scans use water in the blood as an endogenous tracer. These water molecules are labeled at the base of the brain using radio frequency pulses. And after a period of time, we image the water that's perfused into the brain tissues with arterial blood flow up here in the imaging volume. So you can apply the labeling as a slab or as a plane through which inflowing water supply passes. So here I'm showing you just an example application of a plane that is applied in between the 2 twists of the carotid artery. And so in this way, we record several types of images. So some of the images are tagged or labeled, and some of the images are recorded without any labeling, and they're called control images. And the goal is to then be able to subtract these tag and control images from each other and average these different images and then apply a perfusion model to this. And what we end up with is an absolute perfusion data for the entire brain. And absolute perfusion is measured in milliliters of blood per gram of tissue per unit per second of time. And here I'm just showing you the different schemes through which ASL can be applied. So we use this type of imaging modality to study stroke and reading deficits. And to give you a brief background, acquired dyslexia or acquired reading deficit affects about 60% of patients with aphasia and can occur in the absence of other language deficits. There have been different subtypes of reading deficits identified. So for example, alexia with agraphia. So a reading and a writing deficit. Here's an example of a brain scan and a writing sample of a patient with this deficit. They have a classically located lesion in the ventral occipital cortex, and also here in the left parietal cortex, which is responsible for the writing deficit. Alexia without agraphia or pure alexia. Here's an example of a brain scan of a patient with this type of deficit, where there's more extensive damage to the left occipital cortex, but there is no corresponding damage to the parietal lobe. There are also deep dyslexia, surface dyslexia, phonological dyslexia, and these are just based on the type of reading errors that the patients present with. In our research, we have found that characterizing these same types of dyslexia can be done with just using 3 information processing components of reading, including orthography, phonology, and semantics. So in our model of reading, we record processing of letters or orthography, processing of sounds or phonology, and processing of meaning or semantics. And the theory is that reading arises as an interactive activation of all of these processes. So to study perfusion and reading together, we recruited 31 first ever left hemisphere stroke patients who were within 5 weeks post-stroke and were fluent in English prior to their stroke without any other neurological conditions. We studied these participants at 2 time points, the first time within 5 weeks post-stroke, the subacute period, and the second time 3 months post-stroke, or the chronic period. And we recorded behavioral assessment and also MRI scans. For MRI, we used 2 types of structural scans, the T1 and the FLAIR, to help us identify lesion location, and also we recorded ASL for blood flow measurement. And then we also measured participants' processing of semantics, phonology, and orthography using touch screen tasks. And we also asked participants to read aloud words and pseudo words to the best of their ability. We hypothesized that improved reading is going to be associated with improved perfusion or improved cerebral blood flow in 3 potential areas. And number 1 was the area around the lesion. So to illustrate, here's the brain, here's a map of the lesion, and here's the area around the lesion, shown in red here on the image. And the reason for this is that typically in the brain, adjacent areas play similar function. So we thought perhaps the adjacent areas will compensate for the lost function due to the lesion. We also thought that perfusion might increase in the left reading network in the spared components. So we use a whole network of brain areas to enable us to read. And if some components of that network are damaged, perhaps the other components can compensate by increasing in their activation and increasing in perfusion. And lastly, we thought that the right hemisphere may take over the function of the damaged left hemisphere, and so there may be an increase in the right hemisphere perfusion. So overall, here are the results of our perfusion studies. So I'm showing you on the x-axis the time frame from subacute to chronic period, and these are the different areas where we measured perfusion. So the biggest effect that we observed was that the right reading network, so there are components of the reading network that are in the right hemisphere, so those components had increased perfusion both subacutely and chronically compared to all other areas that we've measured. Now looking at how perfusion predicts behavioral recovery, we saw quite an opposite pattern. So here I'm showing you a positive correlation association on the left here with acute left reading perfusion and phonology task accuracy during chronic period. So higher perfusion in the acute subacute period was predictive of better recovery in the chronic period, but on the left reading network is beneficial for
Hello, I think we might have lost connection with Dr. Bukrina. So I'm just going to start the question and answers. I will be reading a few questions to the speaker. We did get a few questions. The first one that we got was, will the slides be available after the webinar? They will be available within about a week. Another question we got was for Dr. Dobriakova. What the question is, what screening was done to test any language impairments due to TBI before learning activities? Also, did you test for level of language? How did you account that your results may be related to language and not learning?
So we did not test for language specifically. I would assume that, or I would predict that language would affect all conditions, immediate, no outcome, and delayed outcome conditions similarly. So language probably did not contribute to the differences we observed between the delayed outcome and immediate outcome conditions. But the standardized neuropsychological tests that we did administer were related to executive functioning, memory, and processing speed. And we see, so far we see an association with executive functioning for between executive functioning and accuracy on words from the delayed outcome condition, while memory is associated with immediate outcome condition.
Okay, thank you. And then we also got a question for Dr. Kira Volati. The question is, do participants in the cognitive rehab therapies have to continue with follow-up therapies to maintain their improvements in memory and processing speeds?
That's a great question, and I'm going to address them separately. So for the story memory technique in that clinical trial, and actually both the MS and the TBI clinical trials, we did a 6-month follow-up. And at the 6-month follow-up, we did find that the treatment effect was maintained for that 6-month period of time. And they did not engage in additional therapy. There was a booster session group. However, there was no difference between the booster session group and the non-booster session group. So the booster sessions were clearly not necessary to be able to maintain the treatment effect over the 6-month period. For the speed of processing, we don't know yet. The data that I presented today was pilot data. We did just finish the clinical trial, and I will be analyzing that data. It does include a 6-month follow-up, but I don't know the answer to that yet because I haven't analyzed the data.
Okay, thank you. And we do have a few minutes if anyone has any other questions. Okay, we just got another question. What advancements do they expect in the coming years?
That's in terms of neuroimaging. Katya, I don't know if maybe you want to answer that.
Do we have Olga back?
No, I don't
No.
see her. She's
No.
no.
Well, so the advancements, it's hard to say. There are a lot of methods that are being developed now. I know some groups in California are actually doing a lot of neuroimaging that are pre-operative, and that involves interpreting scans from single individuals. So I think the field is moving into trying to do that and make the data interpretable on a single case basis, because at the moment most techniques and interpretations require rather large samples, and we know that the individual factor is very important. So the advancement would be in gearing it towards more individualized approach, and also of course multi-site studies so that we can get larger samples will also bring more advancements. So now there are a lot of initiatives that encourage data sharing. Of course, we have model systems that also allows to examine large samples of individuals with traumatic brain injury. So that's the anticipated progress in the coming years.
Okay, and then we just got another question. Are there any effects of COVID-19 that can be seen in the neuroimaging?
That's a great question, and I have actually been reviewing the neuroimaging, not only neuroimaging, but the general neurology literature as it relates to COVID-19, and I have not seen anything on neuroimaging yet out there. We have not done anything. We're hoping to at some point, but we're not even using our scanner or seeing patients at this point in time. So we're hoping that as time goes on, we'll be able to begin to address that question, particularly in persons with traumatic brain injury and persons with MS, but we don't know how that's going to pan out in the future. As of now, there's nothing in the literature that I've found yet.
Okay, and are you working on any other cognitive rehab therapies to address other areas of function?
I actually am presenting this afternoon on another treatment protocol that we've developed for memory dysfunction, again, memory dysfunction in traumatic brain injury that is part of our TBI model system. We don't have data yet, but I will be presenting the pilot data, and I will be presenting on the ongoing study that we're currently doing. So we do have that ongoing. I personally focus my work on memory rehabilitation. However, there are others at Kessler Foundation that focus on other aspects of cognitive dysfunction and have been doing clinical trials with other modalities. We have one scientist currently doing work on REACOM, which is widely used in Europe, not used as widely in the United States, but we're looking at REACOM to look to address prospective memory impairments. REACOM also has other modules that address speed of processing, executive functioning, various other aspects of cognition. There's not been much done with TBI yet, but we're hoping to do more as time goes on, because that does look promising in regard to its impact in other populations.
Okay, so I don't see any more questions coming in. So I'm just going to say that this concludes our workshop. Please complete your evaluations, refer to your email with the workshop links to select your next workshop, and we will begin the next one in 10 minutes. And thank you all so much.